Parth, can I ask you to start the live stream, please? And could you indicate to me when it's up and running, please?
In case you can't see the chat, Mark, Parth just said we're good to go.
Thank you, Fee. In which case, welcome everybody to this meeting in public of the board of the Herefordshire and Worcestershire Health and Care NHS Trust. We happen to be meeting what appears to be perhaps even the first day of our 3-day summer. So fingers crossed. There's a slight change to the agenda this morning in that we will be taking the patient story first before any of our normal administration minutes, etc., for logistical purposes. So without much further ado, I want to hand over to Natalie, and whilst doing that, remind everybody that we've had the 2 videos we watched. Natalie, over to you.
Thanks very much, Mark. Good morning, everyone. So I'm Natalie. I'm the Director of Nursing and Quality. Really delighted to be joined by our HAYS team, which is our Housing Adaptations and Specialist Equipment, which is really in celebration of our OTs as well. It's an OT-led service. So really delighted to be championing AHPs here today. As Mark said, board have had the real luxury of watching 2 patient videos. We saw Delhi, who was been working for the NHS for 44 years before accessing our services, and talked really amazingly about the adaptations her OT delivered to enable her to physically feel better, but also mentally really improved the quality of her life. And then we heard from Sonia and her son James, who has cerebral palsy, about some phenomenal equipment they've had installed to really help his mobilisation and safety around his accommodation. So without a doubt, I'm going to hand over to the team. So we are joined by a couple of members of the team. Am I handing straight over to you, Kate? And then we can hear from the service.
Okay, can the service just go first? Shall we go first just to introduce the service first? Heidi, do you want to kick off?
Hello, yeah, I'm happy to introduce the service first. Hello, I'm Heidi Minifee. I'm one of the team leads for HAYS. So yeah, I'll just give you a bit of an overview of HAYS. So yeah, we're the Housing Adaptations and Specialist Equipment OT team, and we do consist of occupational therapists, assistant practitioners, therapy assistants and administrators. We're separated into 3 areas of Worcestershire with 3 team leads, and Natasha's our service lead. And then we see patients, so they're separated by district council areas, so their council tax, who they pay their council tax to. We see patients with long-term disabilities in their own homes, and that's to help prevent or minimise health deterioration, to maximise independence and to improve their quality of life. And we also like to consider the needs of carers and family members as well. Such interventions can be minor or major adaptations through the Disabled Facilities Grant. Housing advice, it could be recommending equipment, both standard and specialist. We also offer advice and guidance around occupational performance to support independence and positive risk taking. We work with various stakeholders, so patients and family members, other health professionals, our home improvement agency, district councils, social services, care agencies, housing associations, landlords, contractors and equipment representatives, so a wide variety of people we have to work with on a day-to-day basis. And we adhere to lots of legislation, but one of the main ones is the Housing Grants Construction and Regeneration Act of 1996. Now, this guides the application of the Disabled Facilities Grant, and the Disabled Facilities Grant will have various functions that we have to adhere to, and it must be necessary, appropriate, reasonable and practical. So the DFG is a means tested grant, and people have up to £30,000 at the moment to support them with any major adaptation work. So yes, that's just a little bit about our service. Hope that's been helpful.
Okay, good morning, everybody. My name's Kate Jones, and I'll get.
I'm Tracy Newman.
And
I'm Becky.
My daughter.
So, I mean, just a quick overview then of my involvement with Mrs. Newman. I came over here to do initial assessment a few months ago now, and from that, Tracy was able to articulate what she was having difficulties with, what she would like, and more importantly, what she wouldn't like. And from that, I was able to discuss with her what Hayes could offer. So, for example, I think the biggest thing, probably from your point of view, was getting back upstairs. Tracy was struggling a little bit downstairs, and you were downstairs living at the time. Jumping downstairs.
I'd been sleeping on the sofa because I was so exhausted to go up to bed. It was such a struggle. And using the shower upstairs, it was only a couple of times a week, if that. And I'd been making use of the downstairs toilet and sink, and my wash products was in there. But then when I went through Kate, I've found a life changer because Kate's supported me. She's understood me. Whereas when I first had my initial stroke 3 years ago, and I had an OT at the time, but she didn't seem to hear me, my struggles, and so I think her name was Helen. But ever since I've met Kate and she's understood me, and I've since got a wet room upstairs, a chairlift, stairlift, and some rails in the garden, which all aids me, and it's become a life changer. So I thank Kate a lot because she's totally understood all my needs and been so supportive all the way through. Thank God.
In terms of sort of physical needs as well, when we were chatting, Tracy mentioned that, and you did, Becky, as well, that Tracy was having some difficulties with swallowing and choking. So from that, we were able to put in a referral to the SALT team for some support, and they have been.
They're coming on Monday.
And also quite concerned about falls as well, in balance. So there's a referral gone through for that, and I understand the waiting list for that, to get support with sort of through physio and balance and strengthening exercises. So the initial assessments are a really good opportunity to have a good long conversation, and perhaps what's on the referral isn't necessarily when you pop out. Sometimes we pick up a lot more, and sometimes it can be different, but it's just a jumping off point really for finding out what the person wants, because if they don't want it, they won't use it, and that's not what we're here for. We want to make it functional. And we had a discussion this morning. Function doesn't necessarily mean pretty. So the rails in the back garden, you painted them, haven't you? And they look absolutely beautiful now. And that was because the back garden's a little bit uneven, and sort of getting access out the back is a lot easier than the front.
It's only a slight slope, but I'm sure you've heard before, when you're a stroke survivor, you find every little hill, because going down it, you nearly go topple over face forward, and coming up it's just such hard work, especially when there's a step involved. And it's become a life changer to me, because I love being out in the garden, so I can go up and down it each day when I feel I can, and I can do it with so much more comfort and ease, because it's less tumbles, now in the garden, as I've got that support. I'm fucking dancing. That's it.
And they've added Amelia as well.
Yeah.
So it's quite handy.
She's very similar. My granddaughter, she's 1. And I always say there's so much in common between us, because due to my disabilities, I need to wear incontinence pads. And I say to my granddaughter, we're so similar because we've got problems down there and we struggle to keep a balance at times. And there's so many that we've got in common.
So
Like
fair
you.
nappies.
Does she
Like
use your
you.
shower chair though?
She hasn't done until the other day.
She did the other
and
day.
the other day she decided that she was going to run. She got confidence in the step. And she was going to run to find Mum. And she ended up getting up the step, but somehow she lost her balance. I couldn't get there quick enough. So she face splattered my pot plant.
Oh dear. She's fine. By the way. She's fine.
She is fine.
So after the installation happens, a member of the team, particularly with the level access shower, will kind of just follow that through.
Yeah.
And
I think
shower
she took a photo.
Yeah, just to make sure it was where it
Because
needed
she
to
came
be.
and helped me to adjust the seat to which level I needed, and which was good because it was nice really to see a face, another face.
Yeah.
You know, but she was so supportive and understanding and things, and you know, because I'd had such a lot going on with building and structural, and it was quite overwhelming at first. But then I got my boost of colour in there, and it's just.
You can move your bed in there.
It's such a life changer. It's, you know, being able to get in the shower if you go to the toilet and you think, I'm just getting in the shower now because I can do it at my own pace. And sometimes I might struggle if I'm having a bad day. But then one of my girls will come in and do my legs. But I can sit in the shower on a proper seat. And if my body ever feel like I'm getting my vertigo, as I sometimes do, at least I'm sat. So I can just take it easy, take that moment to get back to myself again to rest. But it's one of those showers you get in it and you just don't want to get out. So nice, so lovely. But yeah, it's a guaranteed life changer. I keep using that phrase.
But it has changed.
But it's true, isn't it? Yeah. It's been, you know, I couldn't thank Kate enough. So supportive. The other lady that came out. Your
Jenny, yes.
Yeah, Jenny.
Yes, we've got a great team.
Yes. They have. They're lovely. Your turn.
Thank you for that.
Thank you. Thanks, Tracy. I know I'll hand back to Mark because I'm sure there'll be lots of people who've got questions. So thank you so much for sharing with us.
Thank you, Natalie. And yes, I can only echo that, Tracy and Becky and Pebbles, is that by coming along and speak to us firsthand, it gives us so much a richer, fuller picture of our services and how they can. And I noted down life changer 5 times was said, and we've seen it on the videos we've seen as well, and it's very powerful. So thank you for that. What I'm going to do now is move to my colleagues on the board and ask them if they have any questions or points of clarification to enable their understanding. So I'm looking at the screen to see. I did see an. Let me have a quick look. I think Janet, you were definitely there.
Yeah, it was. I was going to say it was me, Mark. Yeah. Thank you very much for sharing with us your experience of the service. I think it was really, really useful, and it gave us such a good insight, I think, into the challenges that you faced before you had all the aids and adaptations, and actually what difference those have made to your day-to-day living, which is so important. And I think that also came out in the 2 videos we watched, which I thought were amazing and really inspirational. And I think one of the key things that came across to me was the fact that actually the therapists and the teams take a really patient-centered approach and actually look at what the patient needs and wants rather than maybe what they think the patient should have, which again I think is really important. So my question was going to be, we've heard great things about this, but I think at the beginning Heidi was telling us that you have to actually obviously fit in with the legislation but also liaise with so many different people, and I think we all know how difficult it is to get just ordinary building work done on our houses without anything else. So I was going to just ask the team, what challenges do you face, and actually how do you overcome those, and how can the trust help you, because obviously the service you provide is wonderful.
Is that to me or to
team?
Yeah. To the team.
Yes, it was to the team. Heidi, I don't know if you wanted to start.
On the spot now. Yeah, I think like you say, it can be difficult, can't it, when you have to link it with lots of different people and organisations and get that communication working smoothly, and the contractors might not communicate very well to the home improvement agency, and so then the home improvement agencies can't communicate to us, so there are lots of bumps in the road I think a big challenge is keeping on top of these things that can take over a year, 18 months, and we have to keep remembering, where's that patient at, what's happening, where are they in that journey, and that's quite a lot, as well as seeing our new patients and our new assessments. It's just having I think we've got to be really organised in our job to manage all these kind of balls that are in the air, really. Julia and Natasha, can you think?
Yeah, I think just to come in, I think the guys obviously do a great job and have obviously large caseloads of patients to manage, all which are very unique patients, and it's challenging to manage. We obviously are well supported with the admin support, which obviously do support chasing up different parts of that patient journey to make sure that we do get the right equipment in and we follow things through in a timely manner. I think maybe one thing that I just did want to raise, and I'm not sure the board are that well aware, that the district councils, particularly Worcester City District Council, as of a month ago, have decided to cap the DFGs at 30k. And I think most of you all know that for an extension, lots of the extensions would be above the 30,000, and therefore they won't be offering any additional funds to that. And therefore we would be obviously having to look ourselves and Millbrook at whether there's any voluntary money to support families with those major extensions. Otherwise, obviously, it is to the family to contribute towards that, which we know will come with its own challenges. Worcester City obviously are the first to go with that, and we're understanding that the other district councils may follow suit with regard to where they stand, I suppose. So the team are very concerned about, from a patient perspective. I think the understanding that we've been giving the team is that they are there to do an assessment of need, and that's what they're expected to do, and that we're advising they need to continue to do that assessment of need. And then if it can't be met financially by the district councils, then that's obviously the next challenge that we need to overcome. Sue, I don't know whether you want to come any more in on that, because obviously you're well cited with Cape Pine,
I was just texting into the chat, actually, Natasha. Yes, it came up this week at the District Chief Executive's Housing Strategy Group. There's been, so for board members who don't know, we've got a head of health and housing for Worcestershire, Harriet Brown. She's line managed by myself. For some time now, we've been trying to talk about pooling the disabled facilities grant because it would spread the risk across the 6 districts. Obviously, that's quite contentious because each district feels that they might well lose control then of the spend, but actually it would enable us to have a more rounded view of meeting the need, as Natasha's just outlining. So a real live topic at the moment, Natasha, and I'm like you, I'm concerned that we might see other districts follow suit. So I'll bring those updates back to board, but the legislation is about meeting need, isn't it? So I realise that it's really tricky for our council colleagues, so it's what we can do to try and find a way through that.
Okay, thank you, Sue. Thank you, Janet. think, Natalie, you showed, but I think Sue probably picked up what you were going to say, I'm guessing. Yes. Okay, so we can move to, I've got Martin and Carol. So Martin first, please.
Yeah, thank you very much. And Heidi, I think you mentioned, continuing on the same theme actually, that services were means tested. Is that our service or the grants that are means tested, or is our service open to everybody in the population, or do we get means tested in some sort of way before we can actually do the assessments?
Yes, so the grant, so anything that was a major adaptation over £1,000, there is a means test. So there are certain passported benefits where people, it would automatically, we would know that they would be able to receive the grant. But then there's a means test, and some people have a contribution then, so they might have a small contribution of £1,000 towards a £30,000 grant. And so it just, yes, and it's all around income rather than savings. So obviously with care and that is based on savings, isn't it? But it is about person's income and also maximising their benefits, because actually some benefits, if they receive them, like attendance allowance, that actually helps them with the means test. So it's quite a complicated means test that the Home Improvement Agency do with the patient. We don't have any involvement in that.
But in terms of our service, it is across everybody, and the assessment is there done. And what I think you're saying is that there isn't a cliff edge around the assessment; it's a graduated cliff edge. If that makes sense. Yeah.
Yes.
Okay. Thank you very much indeed.
And equipment is supplied on loan, long-term loan through equipment stores. So yeah.
Okay. Thank you.
Thank you, Martin. Carol.
Yeah, just very quick one. Thank you, Tracy. I was really struck by what you were saying about, although it was an assessment, it was actually like a conversation, and that you really felt that you were being listened to, and that Kate took time to get to know you as a person. And I think that's so important, and that we need to make sure that we build in time for that to happen, because it would be so easy to just almost do it like a checklist. But actually, it's that conversation that's the really important part. And you hit the nail on the head, I think, Tracy, when you said it's about the stuff you don't like as well as the stuff you do like. And so thank you very much. And I think that's quite a good reminder for all of us that these things do take time, and that you have to be able to listen properly to what the person really wants and needs. So thank you, Tracy.
You're welcome.
Okay, thank you, board. I think the Hayes team is an example of a number of our teams that we've got. They carry out day in, day out fantastic work, and as we've heard today, changing lives. Yet they're pretty well hidden from certainly the general public, unless the public need their services, and can also be seen on occasions to be hidden from ourselves within our own trust. And one of the reasons I know Natalie was very keen to bring forward the Hayes team, as well as other therapeutic services we offer on occasions, is because you're not hidden. Okay, so Heidi, Julia, Natasha and the team, you're not hidden, and we're really proud of the services you provide, and having not only Tracy and the family come along today, but also to watch the videos that the board has seen of another two of our clients that we've changed lives for. It just reinforces to your board exactly how important these small teams are to the public. So first of all, thank you to the Hayes team for coming along today and exposing what you do, and actually giving us some of the problems. It is disappointing but understandable the position that Worcester City are taking. We all know the problems with finances within public services, and we'll just have to watch the space as to whether other district councils follow. And of course, that may cause us additional problems within our own services, but we'll deal with those as and when they come along. And Tracy, Becky, Pebbles, thank you so much for coming along today. It takes a deal of courage, I think, to come along and speak to us on this platform. And clearly, in the way that you've dealt with the issues you're going through, you've demonstrated a deal of courage, and I think you've done so again today. So thank you ever so much on behalf of the board. And Kate, there with Tracy supporting. Thank you as well, Kate, for managing the technology and enabling us to speak to Tracy this morning. Thank you so much. I'm so very
proud of Kate and her understanding and what she's done for me.
And we are as well. We sometimes when you're on a board, you can deal with the big picture all the time. And we're determined not to forget the little picture. And today, the little picture is Kate changing your life and helping you. And so today, Kate, you are the little picture.
Thank you very much.
But no, it's fantastic to hear from you.
Thank you.
Okay, thank you very much, and we'll let the Hayes team and our guests get on with the rest of their day.
Thanks. Bye.
Thank you very much for joining us.
Thank you. Nice to meet you all.
And bye now. Natalie, thank you ever so much for facilitating that and the videos. They are very powerful, and I think they're a good grounding force for all of us on board. And I think the more we see of your therapists and therapy teams, the more it reminds us of those small teams doing a fantastic job. Okay, we had a logistical reason to take that first. We'll now move to the substantive agenda that we had. So welcome to everybody. The apologies I've been given are Lisa, who is on leave. It's a long-standing leave, and I believe at this very moment she's up a fjord somewhere in Norway, and Rob Cunningham, who has been called away to urgent operational meetings within the system. But I know that Matthew can field any questions we may have with regard to operations of the organisation at this moment in time. So we move on then to the minutes of our meeting, which was held on the 16th of May. Does anybody have any either matters of accuracy or matters arising from those minutes, please?
Mark, Carol sent me a very minor amendment that I'll just make on the minutes. It's a very insignificant one, but it was just a typographical amendment, so I'll alter that.
Thank you, Jill. And yes, Carol did copy that to me. So yes, very, very minor, but nevertheless, it's important to get these things accurate. If there is nothing else on that, then we can take those as an accurate record of our meeting. And we move to the action log. Although it says they are all complete, does anybody wish to raise anything on these? I have one to raise, so I'll do that first whilst colleagues are thinking. On 110, which is about the letter, Jill, from myself and Robert to the neighbourhood teams, that was actually sent back in May. Rather than recently, it was sent just following the board meeting back in May. So if that could be recorded, and the only one that's open is 107, which is going to be the subject of a discussion amongst our team, executive team, next week, I believe. Robert.
Yeah, it's just to build on that, Mark. Yes, we've got an away day on Monday where this is part of the agenda. And just as a reminder to colleagues, the intention is that for the September board, we'll have further evolution of the BAF and the risk register.
Thank you, Robert. And I suspect that was going to come up when we come to the BAF shortly. If there's nothing else with regard to those actions, thank you, Jill, for recording, and thank you, colleagues, for getting the actions complete. And we now move to questions from members of the public, and we've had a number of questions, so I'll hand over to Jill to deal with those. Jill.
Yes, so the first question is a follow-up to questions that were raised at the May board, which are obviously fully set out in the minutes. And so the question that's been, or the questions that have been raised are, the first one is, does the board consider the investment of £93,000 of public funds by NHS England in the Worcestershire VCSE Alliance has accrued the benefits in the business case? And if not, why not? The answer is this matter was dealt with through executive delegation rather than being a board level decision. As such, the board has not considered the benefits. There was not a business case. The funding was to support the adoption and implementation of national NHS England guidance to embed VCSE within the integrated care system, which will be assessed through a national NHSE toolkit. The second question is, has the investment of £93,000 of public funds by NHSE hosted by this trust in the Worcestershire VCSE Alliance achieved the national requirement to embed the VCSE in the integrated care system? And if not, why not? The answer is yes. the investment enabled the VCSE Alliance in Worcestershire to build up capacity and capability in line with national guidance. Then the third question is the Trust accountable for the expenditure of £93,000 of public funds on the Worcestershire VCSE Alliance? The answer is the Trust was responsible for ensuring that the funding was utilised and deployed in accordance with the purpose set out in the NHSE guidance. And the fourth question from the individual, approximately how many citizens of Worcestershire have had their health and well-being improved as a result of the circa £300,000 expenditure by the ICS partners into the VCSE Alliance than otherwise would have been the case without the VCSE Alliance? The answer is the ICB take the strategy lead for the system and would be best placed to answer, although we are unaware of any systematic data collection across partners that would enable an answer. And then we have some questions from a different individual. Why did the Herefordshire and Worcestershire NHS Trust choose to pay Worcestershire charities in the region of £130,000 through the Worcestershire Community Foundation instead of using the NHS payment system? I'll ask all three questions and then the answer. What commission, fee or surcharge did the Worcestershire Community Foundation levy on the NHS for facilitating this transaction? And Mr Yates is a governor, it's actually a trustee of the Worcestershire Community Foundation. Did Mr Yates disclose this payment to the Trust? And the answer is the Trust asked the Worcestershire voluntary and community sector to work collaboratively to look at ways they could support people waiting for our neighbourhood teams' mental health services. This was to respond to some significant vacancy challenges the Trust had at this time, especially in Redditch. Worcestershire Community Foundation then acted as a neutral organisation to distribute the funds across a number of organisations undertaking a number of specific activities. The management fee charged on the £129,556 was 3%, so that equates to £3,886.68. Mr Yates declared his interest as a trustee with the Worcestershire Community Foundation when he came into role, and subsequently the funding has also been included in our annual report as a related party transaction. Mr Yates did not have knowledge of the payment until after it had been made and identified in the accounts. So those are the questions and answers, and written responses will be sent to the individuals probably tomorrow.
Okay, thank you for that, Jill. We now move on declarations of interest. Reminder to any colleagues who have any declaration of interest to make sure they are updated to Jill, and they are then subsequently published on our website, which then takes us through to item number 9, which is the Chief Executive's report. Robert.
Thank you, Chair, and good morning to everyone. I'll just run through as usual, start with the national. Quite an important letter that we've received from the national team around focusing on ensuring that we've got a good oversight of both the quality and experience of care within pressurised services. I think you'll all recall there's been a number of recent television programmes and the like that have identified failings in care. This one in particular was around Channel 4 Dispatches documentary. The letter set out, which is in the report, some particular actions that we as a board have been asked to ensure are in place, all of which you'll see are things that we are working through either with our system partners or we have been progressing quite stridently, I guess, as a board in terms of making sure we're doing regular safety walkabouts and the like. Matthew is obviously leading on this as our Chief Operating Officer, particularly in conjunction with partners, but really important reminder to us as board that we need to make sure we keep the focus and oversight on maintaining the quality and experience of care for our patients within those pressurised systems. So that was the first one I wanted to draw out. Just moving on then from the national perspective as well. We're all aware that there was a recent cyber issue event in London, which had some significant detrimental impact on patient care. Really, this was just to alert that and then link that to the final part on our local part around the trust, which is just in terms of identifying how important it is that we focus on things like the Data Security Protection Toolkit and Cyber Essentials Plus, which we both are aware that the Trust takes very seriously. If Lisa was here, I'm sure she'd draw out those as being important parts. It was really just to provide some assurance to board that we are doing all that we can to ensure that systems are safe, although clearly cyber is an increasing area of risk. I know Matthew will touch on later in the operations support, but maybe there might be a comment from John here just in terms of the industrial action, which is clearly very topical. We've had the junior doctors recent industrial action. Obviously talks are ongoing and we all hope that there's going to be a resolution soon. Overall, as Matthew will pick out later, it is clearly an issue for us, but maybe more so for other parts of the system. The other one I just wanted to draw board's attention to was we have potential action, although we're not sure in terms of the form, which will arise within primary care through GPs who are pursuing their concerns around the current contractual arrangement. So we are waiting to see how that develops, but it is something we are planning for. And again, perhaps I'll invite Matthew and John to draw something out a little bit later. The other one I will draw out just to segue to really, we've got the national appointment of the Medical Director for Mental Health and Neurodiversity. Whilst it's not in my report, I did just want to draw out, we've had very recently, I think yesterday, the SEND report published for our system, Worcestershire, where there's some areas of action that are required. System partners are clearly taking that very seriously and drawing together. Those of you who maybe touching on the ICB board meeting yesterday will be aware that that is the case. Lead agencies are obviously the ICB, Worcestershire County Council and Children's First. We're a key partner in this though, so we're very much involved in that, and hoping to draw out some ways to address some of the capacity and other shortfalls we have there. Just turning to the regional part, a piece of certainty, which is always good news, is around the system plan. So we have received confirmation that our system plan has been accepted. You'll all be aware it is a very difficult plan to deliver, both in terms of some of the operational performance asks as well as the financial constraints on us. However, we have a plan. Board has looked at that. We're four square behind delivering our element. We're working closely with partners to make sure that the system can deliver the plan in aggregate. So some good news in terms of achieving a settled plan, but clearly the hard work is from here for the remainder of the year. Next part I just wanted to draw out was just as a reminder really from the report. We talked about linked nurseries and a really important issue for us last time around, how we were hoping to secure a new partner to work with. I'm delighted to say that we've agreed with Stepway to take on that lease and provide a really hopefully beneficial service, which is particularly focused on needs of veterans as well as the wider community. Sue's our lead on the engagement around that, and just happy to report that. And then the final bit I want to draw out, you'll notice there's quite a few events in there that I've picked up, which are around supporting and celebrating a variety of issues. So carers and volunteers who do such great work for us, supporting those, raising awareness of learning disabilities, and of course our commitment to raising inclusion standards within the trust and supporting Pride throughout June and beyond. So those are the points I'd like to draw out for colleagues here, and my team and I are happy to pick up any particular questions.
Okay, to start with, thank you, Robert. To start with, I've got Sue. Sue.
Thank you. May I just ask you a little bit about the, I think, is it the 7DS clinical standards, and that provider boards should receive reports on those. Would we be included in that? Because I notice it says that it's across the system. So would we receive information about those audits?
Sorry, Sue, in terms of the pressurised services?
Yes. So you mentioned the 7-day hospital services audit results, and I was just reading what that was, and I just wondered if we would be included in knowing about that.
We would be through our system working. I'll probably draw Matthew in a moment. I guess visibly the point I just draw board's attention to is obviously got the performance report, which picks up overall system performance against a number of those key national standards. In terms of the granular work we're doing around services and making those more responsive and performing better, that's a system piece of work. Matthew, is there anything that you can add around the urgent care work that we're undertaking?
Yes, I only say the 7-day hospital services, they're focused mainly on acute hospitals, ensuring that you know what happens on a Sunday is the same that happens on a Wednesday afternoon. Obviously key to safety and quality and flow. We're engaged in discussions with our acute partners, ICB and Worcestershire County Council, and I'll go into a little bit more detail on my operations paper later about some of the programs we're working through.
Okay, if there's nothing else, then there's a couple of things I just want to emphasise. The fact that there's been a medical director appointed for mental health and neurodiversity at a national level. This is the first time such a post has existed, and I think that's a real positive step to ensure that the voice of mental health and neurodiversity is heard at the most senior levels on the NHS board, and that can only cascade down through the system to make sure that voice is loud and clear. So that's very, very welcome. And on a similar theme, it's the fact that Stepway have I believe we're still in sort of a negotiating stage, or we awarded contract either way with regard to Link Nurseries. We are a silver award winner as a trust with regard to our work with veterans, and I think this can only enhance our work with veterans, and that's very much to be welcomed. So to whomever has been behind the scenes in facilitating and ensuring that contract has been awarded, then congratulations and thank you for that. Okay. Thank you, Robert. If there's nothing else, then we'll move to a board assurance framework and the high level risk register, which we've already heard mentioned, but Jill.
Yes, as Robert mentioned, we are still doing quite a lot of work across both risk management and the board assurance framework. Our focus over the last few months since the board approved the risk management strategy has been in relation to local risk management with SDU leads, their deputies, making sure that they're taking ownership of risks within their area. And that work feels really positive. We're making very good progress in terms of greater consistency of scoring, of escalation and articulation of risks. And certainly I've heard colleagues comment on that at committee meetings. The next stage of the work is with executive colleagues about making sure that we are reviewing risks across themes, so things like looking at clinical risks and any escalation that's required, workforce, finance, performance, etc. And we've got coming up meetings with the risk oversight group and relevant executive colleagues to look at that. And as Robert has already mentioned, we've got a dedicated chunk of time on Monday at our next away day about then looking at how we're using our board assurance framework and how risks are escalating up to that. Obviously, with the review of our trust strategy as well, that will clearly have an impact, and we're just thinking about how we anticipate changes may occur there that will impact on the board assurance framework. The other area of work that we're looking at the moment is providing a much greater linkage between the trust priority programmes and how we are anticipating, how we're addressing the risks that appear on our board assurance framework, so that you can see a much clearer read through from operational level risks, the strategic and high level risks, and the programmes of work, and what we're doing then to try and address those very significant risks that we face as an organisation. And just the other area I did want to mention was I've had discussions with our internal auditors, because we have 2 pieces of work that they're going to be doing over the next few months. At the end of Q2, they're doing a specific piece of work looking at how embedded the work arising from the GGI work that people will be familiar with, how embedded that has been in the organisation, by actually talking to staff in SDUs, talking about their understanding, and looking at how effectively we've addressed some of those issues. And then a bit later in the year, they're also going to be doing, as part of their Head of Internal Audit opinion, then having a look at how we're using our board assurance framework and how the board are using it, and how we're planning our agendas and that type of thing, focused on the risks that the organisation is facing. And we're just in the process of organising at the moment a session for board in November, which will be an externally facilitated session about effective use of the board assurance framework at board level. And so that's obviously going to contribute to that. So there is quite a lot that's still ongoing about risk management. So I wasn't planning to go through in a huge amount of detail the current version of the board assurance framework. We do have some high level risks that are clearly scoring above 15 in the report. So I'm happy to take questions, or it might be that I'll ask colleagues who have greater knowledge about some of those to take questions if there are any.
Thank you, Jill. And as you've heard, it's very much work in progress. But then when we're managing our risks across the organisation, I don't foresee a time when it won't be work in progress, because it's always continually changing. A couple of questions, people want to ask questions. Sue first, and then Janet, I think. Sue.
Thank you. Well, first of all, I'd like to say that it's really, really heartening to see the work that you're doing, and it really is increasing sort of clarity and comprehension of the risks as far as I'm concerned. So thank you very, very much. In terms of strategic objectives, and obviously you list a number of mitigations in terms of risk to quality of care. But as I read the papers, there were many others that sort of popped up through readings, such as you could mention on-site advocacy, which is obviously a mitigation in terms of our mental health provision. The way that we're using care opinion is also helping us to guide quality of care, the getting it right first time work streams that we're doing, the clinical strategy implementation programs. So when people write their reports, they often identify which risks of the BAF that we're talking about, but then those are not sort of translated into the risk register or the BAF framework. So I think there's many more reasons to think that we are doing our very best to mitigate the risks there than maybe we've listed. I was interested in the one of the risks being the quality of care and culture on some adult acute inpatient wards, and I wondered what that was a reference to. And then in terms of the higher risks, the risk 1399 and the Herefordshire PCC MHS vacancies, it's got a target date of the 30th of June, and you've very helpfully given us lots of presumably extracts from Ulysses to show what's going on, but I just wondered if that target date needs amending, because it doesn't sound as if it's been resolved yet.
It may be that I'll ask John to comment on that. So John, that's on 64 of Diligent. I know that's a risk that we've previously had discussions about. I don't know whether that's been impacted by the absence of a member of staff there.
Yes, that's correct. So the issue remains around how fragile the medical establishment is in Herefordshire. However, we have mitigated that risk extensively by using our insourcing policy to use existing doctors to cover gaps, but also we have been fortunate to get some good agency locums covering the gaps as well. So the mitigation around patient safety is really good. However, because of the insourcing and people being stretched to cover other areas, there is always the risk of staff burnout. So we are carefully monitoring the situation, and the risk scoring hasn't been reviewed, Sue, because the risk owner has been off due to personal circumstances. So once he's back, we will have that reviewed.
Thank you very much. May I just ask about that comment, quality of care and culture on some adult acute inpatient wards? Is that referring to a particular thing?
I think Natalie's indicated she'd like to come in and comment on that. So, Natalie?
Yeah, I'm happy to comment on that. So this is the work we've initiated with both Meaningful Care Matters and the Culture of Care programmes. So nationally, we understand that there are multiple issues affecting mental health acute inpatient wards, specifically around levels of acuity, the workforce, the therapeutic models, how we effectively care for our staff. And we've seen nationally on things like Panorama that there can be then impacts on culture of care and the CQC closed culture work. So we've engaged with two organisations. One's a national programme, one's a bespoke programme that we've tendered for, to look at the culture of care, and we're using all of our inpatient mental health wards, so it's going across acute inpatients, older adults and rehabilitation, which will really effectively, we've done the deep dive, we know what the that their initial recommendations are for our adult inpatient wards, and then there's a bespoke package of care they put in place in relation to supporting the team and the service with really good focused recovery based interventions to improve the culture and the care delivered.
So does that mean it wasn't a specific thing that arose, but more that generically we're looking at it, and then in looking at it you find issues that you want to address?
Absolutely, yes. There's nothing specifically that's triggered that particular risk being raised, but there's multiple components to that makes that risk really important that we look at and address.
Thanks, Natalie, and thanks, Sue. I believe Sue asked one of the identical questions that Janet was going to ask on exactly the same risk, so that point has gone through. So well done, Sue. If there's nothing else, we're being asked to agree the BAF as it stands at the moment and the high-level risk register. If we can agree that, please. Thank you. I will remind board that at the end of the meeting, we'll be revisiting to check if anything we've heard today, any of our reports or discussions, means that we think there's something else that may need to go into or be amended on the BAF, and that'll come towards the end of the meeting. Okay, if we move now on to item number 11, Sue, and our trust priority programme.
Thank you, Chair. So as we've just talked about, this is still working through in terms of really triangulating with the BAF and our strategic risks, but hopefully with this paper pulls into one space now all of the board priorities which we agreed back last October, threading through 24-25. I'll take it as read, but I just wanted to extract a few things for board colleagues. You'll note that we've gone into phase 3 of the rollout of the clinical strategy, and just to confirm, that is the neighbourhood mental health teams. So that's that entire service portfolio. So larger grouping than we've done before, but we've got the learnings from phase 1 and 2. So that's a really exciting implementation piece. We're still doing the work on community paediatrics. Some of this is changing because we've got the outcomes now, as Rob referenced earlier, from the SEND inspection. We've got the work we're doing with our integrated care board colleagues on the business case. And obviously this afternoon, we're going to do a deeper dive into children and young people per se, and we'll pick up some of the detail then. The board priority about patient and carer voice, really mobilising this, and thank you, Sue, for picking that up. We know we've got lots of work happening in this space, And it's just to pick out that the care opinion rollout continues to go well. Still the highlight of my week when I get the stories every Friday. And we're moving out now into phase 3, and we're taking in some new teams. So we're really moving into children and young people's. Actually, they've, since the senior leaders, when we talked about this, been a lot of appetite from that SDU to really push out now into care opinion. And we're using our youth board, a new very dynamic group of people, to help get into that space to make sure it's tailored to get the maximum input from children and young people. The work around urgent care is very much still live. We've got ongoing conversations around the virtual ward rollout, still somewhat funding dependent, but doing the work in the system space around frailty. Also wanted to pick up the mental health collaborative. So the committee will, Carol will cover this later, but we've had a deep dive into the dementia diagnosis rate. We've also considered that as a board, and that's on the agenda later. And the last meeting, we looked at learning disabilities and autism, which actually, for a small service, so important to us as an organisation. It was really good to see all of the detail played out there in terms of the work we can do as the organisation, how it fits into the system, and that's a key priority for us as an organisation. The work around Arise continues to sharpen. So just to pull that through, that's obviously a key part of the workforce portfolio. There's a lot in this report. We've tried to distill it down, but yeah, happy to take any questions.
Thank you, Sue. And I should have said at the commencement of our meeting today, actually, thank you to colleagues on the screen and in beyond for the work that I can clearly see on trying to make our reports to this board more punchy, more focused on our priorities. I think, Sue, this is a great example of that, to focus on the bits that we need to focus on. So I recognise the shortening and the focus of the report. So thank you very much. I know it's work in progress for everybody, but it's certainly starting to show dividends and enabling us to get to the heart of matters on this. Janet.
Yeah, thank you. I thought I'd try and get in before Sue this time. She must be the same as me because she asked a question earlier I was going to ask too. Okay, so I got 2 questions on this one. The first one was around that some of the areas we haven't got assurance levels. It says current assurance level not applicable at present, and I just wanted to ask what that means and what the plan is for actually having an assurance level there. And then the second question I got was around the virtual wards, that I noticed you say that a position statement was sent in on the 24th of May and you're still waiting. And it seems to me as though virtual wards are a fundamental plank, as you say, of the frailty programme and of, out of hospital care and all those things. So I wondered, can you give us a bit more insight into what's happening there, please?
Thank you, Janet. I'll ask Matthew to come in because Rob is not here and he's all over the detail here. But just to say about the assurance levels, this is predominantly because the ones where we haven't got an assurance level, we've not really taken through Programme Management Board. And so my request really is we could start to do that. So things like the clinical strategy, it's a board priority, and it goes into quality and safety, but we haven't really said, well, we want an assurance level around that. So that's why my preference would be to colour code it and to put an assurance level in and to make sure the governance is clear, Janet. So, in that case, that one for clinical strategy does go to Q&S. So I'll go back to the team. We'll be really clear on which committee is overseeing the assurance level, and the next report we'll try and assign assurance level to each one. And then sorry, Matthew, do you want to come in around the system conversations around the out of hospital work?
Yes, I think the question was specifically about virtual wards. Obviously, as you're aware, we have our initial pilot in place in the Wyre Forest area. We have developed resource across the rest of the county. We're in discussions with system partners at the moment about how the medical leadership and oversight for those is best provided, and to secure sustainable funding pathways before we're able to fully commit to roll out and keep those virtual wards going. There's also detail that we have to still agree about numbers of virtual beds provided as well.
Thank you, Sue. Thank you, Matthew. Is that okay, Janet? We'll move to Martin.
Yeah, Janet has particularly gone trodden over my question, but I do want to explore more on virtual wards, because around the country, they are being seen as critical tools for increasing quality and reducing financial risk and financial cost. And we seem to be having prolonged discussions about investment in what is in other areas sort of seen as a no-brainer. I'm just wondering what is getting in the way of that decision, and are we learning as a system from others who have done this successfully and have Acute Trust recognizing that it is offering up significant savings?
It's probably right for me to hand to Robert around system discussions.
Yeah, so I think there's a couple of things that are going on here. I think the main thing that's changed, which is very positive, since probably around about March time, is that the discussions that Matthew talks about, particularly the clinical oversight, the medical leadership, is now thoroughly a joined up conversation we've had with primary care and with our acute trust partners. So this has been picked up through Worcestershire Place as well. So we've probably gone from a place where we were pushing on, developing a model, working that through, and then coming up against some gaps, particularly around the medical oversight. That has been part of the really mature conversation that's been happening. So we are now at the point where we have pretty much a joined up view around how that needs to work. And there are some differences in terms of how the model used to work and how it does work. So particularly sort of the whether that sort of is admissions prevention or post discharge and how we get that. And that's been a really good conversation. As Matthew says, there's still just a couple of bits to iron out around that. And then there's that discussion that we need to have with the ICB around this is the model we need and actually how we roll it out. Now, that is when we come up against the issue obviously around funding and affordability. There is some funding set aside and there will be funding in future years, but clearly we have a system that is financially challenged. And we need to be quite clear about how investing in this part will have some benefits for the rest of the system, just making sure that we can track those through. So I think the reality is, Martin, that is quite complicated, but important, as you say, and we need to get it right. It does seem to me that we're in a much better place in terms of a system proposition. We just need to follow that through in the next couple of months with the whole system to get to that solution. There's other bits which are complicating it as well, which I'll just throw in there, which is around, obviously, we'd like to see more capacity in community care setting to help take the load and the pressure off the front door and actually in the acute setting. And again, that's part of the national agenda. But again, it's difficult in terms of how you release funding to make that happen. And again, that's a system conversation we need to work through.
Thank you, Robert. And just if I may just add to that, one of the GPs that was fundamental in the success at the Wyre Forest rollout of virtual wards is now on the Integrated Care Board. And so that voice will be heard loud and clear within that sphere as well, which just adds to what Robert said about it becoming far more collegiate and systemic that we're trying to approach this. Okay, if there's nothing else on that one, if we could note Sue's report, and again I echo what I think Sue put in the chat with regard to the colour coding and the development of all these reports today is great to see. Thank you. We now move to item number 12, which is the CQC must-do actions. Before I hand to Natalie, it's probably fair for me to say Natalie, Robert and I had a discussion around, as we continue to do so really, around our improvements. And this report is with regard to the fundamentals around regulation. that are within our improvement plan and are being addressed through our improvement plan, but these are the bits that are really at the core of what we do as an organisation in regard to our regulations, and that's why it's been brought forward as a separate item for board to take oversight and assurance on. Natalie.
Thanks very much, Mark. So if I can just remind board, so we have 35 must-do CQC actions, and a must-do action is a regulatory compliance where we have the CQC have found us not to meet the basic level of fundamental standard for that regulatory activity. So they are attributed to both our trust-wide activities as well as allocated to the 4 core services that were inspected in our well-led inspection. So this report just gives you an oversight of the work that's underway. You'll note we've given it a relatively low level of assurance at the moment, and I just wanted to bring to board's attention that's because whilst many of the actions are underway and we have no concerns about them being achieved within the relevant timescales, what we're really doing is we are really critically appraising ourselves of the fact that we are able to evidence our success against those must-do actions and provide a sustainable solution. So what I'm really clear about is that whilst we may have achieved some of them already, until we're guaranteed that that's a sustainable solution, we haven't said that action is complete, which is why some of the timescales might seem longer to board than you would initially expect. So as I said, none of them at the moment are highlighted as a concern or need to be escalated to board that I don't think we're going to achieve, but it is that requirement for the additional scrutiny to make sure they're well embedded into our processes. I'm really happy to take questions.
Janet, who I suspect will ask the question that Sue and Martin were thinking of.
Actually, it's sort of not a question, it's a bit of a question. And what I was going to say is that obviously we've had a big discussion about this at Quality and Safety Committee at our last meeting, and that this paper is, you know, a different paper to the one that came to the committee. But we did crawl all over it, I think it's fair to say. One of the big discussions we had was actually around how we measure the impact of these must-dos and how important it was, as Natalie has said, that it's not just a tick box exercise. It's actually looking at what the impact is of these actions for our patients. But I suppose the question is actually, Natalie, and it's a sort of a big question, but it's how do we make sure that we are getting a measure of that impact and that it is sustainable? Because very often, you know, with these things, you sort of do it and tick a box and then move on to the next thing. So how are we actually doing that? Is it going to be through integrated governance and things like that?
Yeah, so what we've done is we've woven all of the actions now into each of the integrated governance committees, so that in the well-led section, so we use the 5 domains of the CQC to format our integrated governance committees, and that now goes right down to the SDU level and to team level. And so under the well-led, we've got the CQC must do and should do actions coming through there, and we're getting a really clear reporting now against those and where they are and how much impact they're having and how we're monitoring them. So yeah, it's woven through, and that's the sustainability piece to make sure that that governance is really clear month on month and that the right things are being escalated. That's the key component.
I've got Veena and then Martin. So Veena first, please.
Thank you. Mine is kind of a tick boxy question in some ways, in that you know, it's good to see some of those boxes being ticked, but I just wondered how do we know that we're doing what the CQC think we should be doing? How do we know we're hitting the mark? Is there some sort of feedback process so that, you know, when they come back, we're not sitting there kind of being told this is not what we thought you were going to do?
No, great. It's a really helpful question, Venus. There's a couple of things to that. So one is that we are, when we're ticking the box, we are collating the evidence. That evidence is how we've ticked that box and why and how we've achieved that. Now they're being compiled, and the CQC portal, where we are now encouraged to provide evidence to the CQC of our progress, as soon as we get full access to that, we know some organisations now have, we're on the waiting list to still join. We'll start submitting through that portal, and that will be the way we're able to update the CQC regularly as to how we're making progress. But alongside that, we're still one of the organisations that's having regulatory engagement meetings. So our local CQC inspectors are still happy to meet with us for an engagement purpose. So we've kept them up to date with progress, as Scott's been meeting with them to really update them against the improvement plan, as well as our CQC actions. We've got a meeting with them next week, so Scott and I are meeting with them. So we go through, we provide the information, and at the moment they're giving us really positive feedbacks about, yeah, absolutely, you are doing what we thought you should be doing, and you're making the progress that we wanted to see. And they equally understand that balance about progress, but making sure it's sustainable progress is really important.
Before I move to Martin, I think Robert probably wants to comment. Did you want to comment on this one, Robert?
It was just a point to Natalie. It might help if you just gave a couple of examples of the sort of things that we're doing, because I mean the report talks about the number and so forth, but for those not as close to the detail, they might have forgotten exactly what sort of things that we are having to do are, and that will probably just tie through to the discussions we're having with CQC and understanding about that.
And before you do that, Natalie, just to close the loop on the Vina question, when the portal's open and when we submit evidence, do the CQC give feedback on that evidence? If they receive it, look at it, and if it is the wrong thing, as Vina was suggesting, how do we know we're doing the right thing? Do they feedback on it, or is that what your routine meetings with Scott are for?
So at the moment, the portal's not functioning as fully as it should do. So that's, I think, work in progress. And we all understand the CQC is undergoing really significant changes. So hopefully there will be that feedback loop. And we know that the longer term plan is for any information that we feed into that portal to be used really regularly to reassess us and to change our ratings. So our ratings become a much more transparent item where we'll get a scoring. So you'll see scorings might change on the evidence that we submit, so that data will be reviewed and used. At the moment, we really are relying on that engagement meeting to be that discursive element of, this is what we're doing, have you received this, is that what you were looking for, are we meeting the regulatory standards from your perspective? So yeah, it's that engagement meeting.
And were you going to give some examples, Natalie?
Yeah, so I think there's lots of the examples fall within the governance framework. So in relation to, are we robustly monitoring, for example, clinical supervision, appraisal levels, compliance against training standards, particularly Mental Capacity Act training. So making sure that they are well embedded in our governance processes and monitored through, and there's clear escalation from team appropriately up to where it needs to be escalated. And then we have some very team specific elements. So, for example, leadership on one of our mental health wards and how we've addressed that and the actions we've put into place to make that more robust and supportive, as well as the environment within our health-based place of safety, Section 136 suite at the Elgar unit, and specific actions around doors and furniture and equipment that was in that suite. So they range from governance to really specific service-wide, with some much more kind of detailed ones, particularly around children and young people waiting in 136 suites, which was kind of multi-agency working.
Thank you, Natalie. Martin.
I think between yourself and Vina, I think my question's been answered. Thank you.
Thank you. The non-executive directors seem to be asking each other's questions today. I don't know what that says, but I'm going to suggest it says good things. Right. OK. Thank you, Natalie, for bringing this report forward. I think it is really important that board has a really good oversight on the must-dos. Yes, we have a good oversight on the whole improvement plan, but these must-dos are the real crux of how we're making sure that we're delivering the improvements that we want. I do note that there's a number of these that come to fruition within the next 2 or 3 months, I think it is, Natalie, from looking at it. I didn't get a sense from your report whether you feel there's any risk in those deliveries. It seems all positive that it's going to be delivered, but are there any risks to that delivery in your opinion?
not to deliver it at this moment. I think the risks that we've discussed and we're currently addressing is how do we realign our data and performance information to ensure that they are easily and readily reported on. So at the moment in integrated governance, we have to pull from multiple places to get the information that we need to report really effectively. That needs to be streamlined and made much simpler for everybody to be able to do that in a really systematic way. So that's one of the things that will be very reliant on making this a sustainable plan.
Okay, thank you. Sue.
Will the more negative comments in the send Ofsted have an impact on CQC's sort of evaluation of how well we're doing in certain areas?
The CQC use multiple ways of assessing and considering whether they need to do further inspections, whether they need to do an information-led inspection. So the CQC will certainly be looking at the SEND report and considering, but the two reports are separate, so it won't impact upon our must do, should do. Obviously, it should impact on our improvement plan if there are correlating factors. But yes, so the CQC pull from a wealth of data to inform what their next steps would be.
And I think Matthew wishes to add something to that as well. Matthew.
Just to say, and so obviously you're very well aware of this, the SEND inspection report is a report into the provision of children's services across the system by all partners. So you know, it's generally written in a way that talks about care across pathways, you know, through schools, through social care and health providers together, rather than comments about individual services. And the overall rating as well is completely separate to CQC service ratings. So as Natalie said, yes, it is a source of evidence. No, it doesn't have a direct impact on ratings.
I suppose when I read it, I can't help but identify the bits that probably sit under the trust. So although obviously it's an ICB responsibility, there are bits that we deliver. So obviously there are areas like the speech and language therapy, which are, you know, receive a glowing report, but then there are other areas which I know we'll look at later today, where clearly there are sort of difficulties.
Yes, that's true. But even something like speech and language therapy, that's, you know, it's got a universal aspect, it's got a targeted aspect, and it's got a specialist aspect. So most of the services that are referred to actually are services that are provided by multiple providers across pathways. And there's priority action plan that we're all party to, and each of the parties has specific actions within that.
Thank you, Matthew. Okay, if there's no one else, we're being asked to note this report. And could I just ask board's opinion on, Natalie has been very conservative, I think rightly so, with regard to the level of assurance we are allocating. And Natalie's given a very good rationale for why that is. We need to see the sustainability of the impact going into the future, so we're being cautious. Are we all comfortable with that being left at level 2? I see no dissent, so I will take that as a yes. Thank you for bringing that forward, Natalie, and obviously board will keep a close eye as we move forward, and we note your report. Thank you. Okay, we now move on to item number 13, which is the adult acute pathway relocation, and I think Matthew is going to start us off with this one. Matthew.
Yeah, thank you. So the relocation of one of our acute mental health wards is a significant decision for the board, so I'll be presenting the paper with executive colleagues. I'm going to introduce it and give some of the context. Natalie, as Director of Nursing Quality, and John, as Medical Director, are going to talk about some of the environmental, safety and clinical quality aspects. And Sue, as Director of Strategy and Partnerships, is going to talk about the engagement process. And similarly, questions in follow-up will be fielded by executives in those areas. So just a bit of context and background. So Hillcrest is one of our 3 trust acute adult mental health wards. It's based at the Alexandra Hospital. Across the 3 wards, we've got 51 beds in 3 locations, and Hillcrest currently operates as a 14-bedded acute mental health ward for working age adults. Healthcare, Hillcrest is primarily a Worcestershire-based ward. That is to say, it takes patients from across Worcestershire on a non-geographical basis, with the occasional patient from Herefordshire. So patients are allocated to either Holt or Hillcrest ward if they need admission, based on the patient mix on the wards and the gender mix and the bed availability. And it's been a non-geographical ward since 2016, so it doesn't serve the north of the county as Holt ward does. It serves the whole of the county. As a trust from 2021, we've benefited from an extensive reprovision of our adult acute inpatient estate on the Eliminating Dormitories programme, and that completes later this year with the opening of the Mortimer ward at Hereford, which is the final piece in the jigsaw. The programme has created new fit-for-purpose sites on campus locations. So these campus locations bring together clusters of wards together with their acute teams around them. So the building programme's created a new ward at Elgar in Worcester, which is above current needs due to other service developments. We now have the opportunity to relocate Hillcrest to this facility, and our belief is that will significantly improve the care environment of safety. The leadership team of the Specialist Mental Health and Learning Disabilities SDU and the Trust Executive are proposing that we now proceed with this relocation, and as Chief Operating Officer, I endorse this proposal.
Thank you, Matthew. So I'd just like to remind Trust Board a little bit of the history around Hillcrest, and if we briefly go back to 2020, there was a risk limit process in relation to Hillcrest and an improvement plan that was attached. Whilst that did make some initial improvements, we then had further concerns in 2022. In the summer of 2022, we started engaging with the CQC around our concerns about Hillcrest, which led to an intelligence-based inspection, and the environment and the CQC rating was downgraded to inadequate. That's led to a really intensive improvement plan that was finally closed in November 2023. And we've had a new leadership team that has been overseeing that improvement plan now in place for 18 months. I think I want to take this moment to note and thank that leadership team for the significant improvements that they've been able to deliver in the quality and the safety of patient care. The improvement plan has been significant and has ranged from environmental issues to staffing, through to patient engagement, ensuring we're hearing the patient voice, the use of on-site advocacy, and engagement with patient and carers, providing a different range of activities. So it's been a significant improvement plan. And I really want to give them credit for their incredible leadership in that and what they've managed to achieve. However, it still doesn't resolve some of the fundamental issues with the actual building itself. So as Matthew alluded to, Hillcrest is an isolated unit. It doesn't have any other units to call up from when there is a situation or an incident that might need a response. And you would never purpose design a building for an acute inpatient ward anymore to be an isolated unit. And that's not something we can mitigate against in the long term. The layout of the unit is challenging. So it was initially a 25-bedded unit. We're now safely managing it as best we can, being a 14-bedded unit with a male corridor and a female corridor. But the design of the unit is sprawling, it's poor for visual physical observations on the unit, and we mitigate that significantly with CCTV and additional staffing. But again, long term, it's not something that we can mitigate successfully. The building isn't built to our modern standards. So, for example, there are no ensuite facilities in the bedrooms, which is now a basic expectation of an adult inpatient mental health unit. And staffing continues to be challenging. So although, again, the team have worked incredibly well, and thanks to the agency that we've been working with to provide really high quality staff that work alongside and are part of the actual team to provide really good care, it still remains a very high vacancy rate at that unit. We had a CQC Mental Health Act inspection this week, and we've had the verbal feedback, and I thought the CQC inspector summed it up really helpfully, and he described that the environment carries innate challenges, but what he saw was that the team had provided proactive and patient-centred care as best they could to overcome that. And it's that reason that I again support Matthew and would endorse this proposal. From the balance of patient quality and safety is as best we can deliver it currently, but the long-standing issues we can resolve in a more modern environment. I'll hand you over to John.
Thank you, Natalie. Thank you, Matthew. I was actually not going to repeat what either Matthew or Natalie was going to say, but I do want to repeat some of what Natalie said, because I think it's really important that we both say it. I just wanted to acknowledge the tremendous improvements that the team have undertaken. The patients currently receive much safer, effective and patient-centered care than they did before. And I just want to put formally on paper my thanks to the multidisciplinary clinical team, which includes the nurses, psychologists, therapists, medics, psychologists and healthcare assistants, but also the administrative and catering and facility staff who have worked with the clinical and operational leads to turn around the quality of care that's being provided there. But also special thanks to the corporate teams as well, who have worked with the local teams to effect this change. I do want to name a couple of people specifically. Laura Sparry, the matron on Hillcrest, and Anna Marie Bainham, who's the ward manager, both of whom used to work in the rehab services, both of whom were people who were identified by Dr. Jitesh Daya, the Associate Medical Director, and who were brought in and agreed to be brought in to turn around the quality of care. And Matthew, Natalie, myself, and Elaine, met with them regularly during the initial stages, and we do acknowledge the personal sacrifices they have made and the type of challenges they faced in turning around the quality of care. So I just wanted to place my thanks to them both, and of course everyone who's wrapped around them to improve the quality of care. However, as Natalie mentioned, we do have some environmental constraints, and a therapeutic environment is so important nowadays. It's not just about the human care that is being delivered, but the environment that you are in can affect your mental health and your physical health and your state of well-being. And I think the type of environments we have at the moment at the Elgar site, especially with the Eliminating Dormitory program and the investment we have made in those services to make them state-of-the-art inpatient services, I think is a good move to move the function from Hillcrest to Athlone Ward. It's going to be much more safer, and the reason for this is we might be able to much more cater for gender fluidity and sexual safety, but also I think there will be much more footfall in a unit which is on one side rather than an isolated unit, and this lends itself to avoiding developing a close culture, as the CQC has pointed out in the past. I also think that this lends itself to creating Centre of Excellence at the Elgar Suite. And I say this because in terms of the workforce, there is going to be quite a lot of mutual aid between the wards. There's also going to be much more opportunity for specialist second opinions to be sought on a responsive manner. And also, as a medical director, especially with the medical school, it's going to be much more easier to place medical students and, of course, nursing students and AHP students on site rather than in an isolated unit like Hillcrest. So overall, I think in terms of excellence, there are much more better training facilities and based on a site, especially with some state-of-the-art facilities we have developed at the Aikenbury site and also the Charles Hastings Centre, I think will lend itself to a much more service that is geared up towards training, teaching, research, and so forth. So overall, Mark, I too am in support of the move of the acute function from Hillcrest to the Athlone site.
Thank you, John. I think you're handing to Sue now, because I think the level of engagement, because this has been ongoing now for a quite considerable time, and I believe, Sue, you've led our engagement on this process. So perhaps you can illuminate the board on how that's gone and what our partners are saying, please.
Yeah, thank you, Mark. Yes, I suppose I want to just recap the work that we've done across the board here to make sure that we've been transparent, open around the challenges, and really listen to some of the concerns. So just provide some assurance around the engagement process. As Natalie said, that this sort of came out as part of the CQC conversation. And we went to our Health Overview and Scrutiny Committee in Worcestershire, and we were really open and said that actually some of this we were really going to struggle to mitigate, especially the location and the layout. They then supported us to come out of actually having a formal consultation as such, but a number of listening events. So we did that in multiple places across 2 counties actually, but obviously predominantly Worcestershire. So you'll see from the paper, there were 2 issues that were raised out of those listening events. One was around public transport availability and cost, and the other one around the perception of parking and the availability seemingly better in the Alex site than perhaps at Worcester Royal. We're very clear that, as Matthew outlined earlier, this isn't a service that is allocated on geography, it's done on clinical need, and therefore we've also been working with these challenges now since 2016, and the wards do and will continue to make sure that where we've got bespoke challenges with people, particular families and carers able to visit, that we will signpost and support people to be able to visit their loved ones. When we did this with the move from Athlone to a community-based service, which meant that the beds were in the north of the county, so in Newhaven, my team spent a lot of time pulling together sheets on public transport, looking at other parking alternatives, and working with the ward to potentially bring in volunteer transport schemes, etc. So that we've got a history of doing that, and that would actually be the case. We do much of that already, but to provide some assurance that we listened, we know that we can do something in this space, but it's not a new challenge because of the fact that they're not geographical located beds. So a number of us went back to HOSC in March this year, and they were very supportive of the ongoing direction of travel. We talked about what we'd heard and what we were doing around that. And John, myself and Matthew were there again last week, and we updated then about the board conversation today. I just want to basically also raise the point that I personally took out the HOSC chair and the Redditch elected member who sits on the Health Overview and Scrutiny Committee to visit both Hillcrest and the Elgar site. They could really see the fundamental challenges that we're talking about here that we can't get over because of the location and because of the layout of the building. So they are also in support and have been throughout actually for us approving and moving forward as a board to basically transfer the service. So again, the board lead around public engagement, transparency, and that patient and carer voice in our decision making, we've gone through a process, and I would also support us moving forward in the way Matthew's outlined. And I think I'm handing to Matthew now for the final piece before we open to questions.
Yes, thank you. Just to follow from Sue's point, really, we've also internally been engaging staff in the conversations about this. on an informal basis, stating our clear intentions to move forward alongside the HOSC process, and we've been doing that since October last year. We've established now a working group. So we've got a working group that includes all parties who are affected by this move, and the working group will effectively project manage the move, which will include now a formal HR consultation with affected staff, because obviously we're moving all staff from one site to another, and that's not going to be suitable for every person. In terms of timelines, the proposed move is to be completed by April 2025. We're very much thinking that as a long stop date. So the preference of the leadership team of the SDU is to move as early as practical. So at the moment, there's still there's few remediation works to be completed on Athlone, because we were using it as a psychiatric intensive care unit, and there's some just minor remedial estates works to be done, and there's some practicalities around facilities estate support. But as soon as those are worked through, we will be making a proposal for, we think, an earlier date for moving. So April, the long stop date, so it will be by April. The possibility is, though, that we will move more quickly than that.
Thank you, Matthew, and thank you for the comprehensive briefing. I think it's important that we hear from the senior clinicians and senior operational lead for the trust, because it's a significant decision, and that's why we've made sure we've heard their voices loud and clear. I'll now move on to questions, and just to say, once we've had the questions, I will be coming to the Chief Executive to seek his views on not only the paper but the what he's heard in the questions that are just about to come out. So questions, I've got Martin, Vina and Janet. So Martin first.
Yeah, thank you very much indeed, and very comprehensive. Apart from one detail, when we issued the improvement plan, we significantly reduced the bed base in Hillcrest, and now we've increased it. I can't see anywhere in the paper that says what is the intention in terms of the number of beds that we will open up in Athlone, and the impact that that will have on positive or negative on out of area treatment.
Thank you, Martin. I'll take that. So the number of beds that we'll be providing when all of our dormitory remediation work is completed will be 50 acute beds. So we've undertaken patient flow modelling on this, so we understand very well what our average number of admissions is per year. It's, you know, apart from the 2 years after COVID, it is consistently around 450 admissions a year. We've modelled through the national average length of stay, which we tend to do slightly better than on the whole. And at 50 beds, we have the ability, with the national average length of stay, we'll have about 4 or 5 beds available daily for admission. So 4 or 5 empty beds, which puts us within the occupation levels recommended by CQC. So we're fairly confident about the bed numbers. So Athlone will open as a 14-bedded ward. So we'll be moving 14 beds at Hillcrest, which is the maximum that footprint can support, to 14 beds at Athlone.
Thank you.
Vina next, please. Vina.
Thank you. Can we just be really clear about the proposed timescales, please? You've just mentioned, Matthew, that you hope to have this move completed by April 25. The paper talks about commencing the move by April 25. Are we hoping that we're going to be fully functioning by April, and does that factor in all the staff consultations, etc.?
Yes, it does. So you know, that may be a difficult choice of language. So by April 2025, our view would be that Hillcrest would be operating, or that the function currently operating at Hillcrest will be operating from the Athlone site, sorry, in the way that it currently does. We're not sure we have to say one of the areas you rightly point out is staff consultation. That's got a minimum time length of 30 days, but it hasn't got a maximum time length in the sense of the time that it would take through to work through individual issues with particular staff. The management team have drawn up a staffing plan which makes certain contingencies and assumptions around a lower proportion of staff moving than are currently employed at Hillcrest. That's part of the detail that's been covered by the working group that will project manage the move.
Thank you, Matthew. I've got Janet and then Carol. Janet, please.
Yeah, thank you. I don't think this is a question. It's just a comment, really, to say that we discussed this in great detail at Quality and Safety, and I wanted to just feedback that everybody who spoke in that meeting, and I think actually most people did, were in favour of the move, and I think that's really important. Nobody actually spoke against it, and you know, we did discuss the impact on patients and patient experience, which is obviously, from our point of view, really important, together with patient safety. The other thing I wanted to say was actually at that meeting we didn't consider the training aspects and the value that I think John has pointed out, that actually if we can have medical students and nursing students and therapy students there, that will raise standards. It always does, and I think that's a really important thing, and to my mind, if I wasn't convinced before, which I was, that would have convinced me. So I think that's a really key element in our patient safety strategy. So thank you for raising that, John.
Thank you, Janet. Carol.
Yeah, so first of all, yes, I think I'm going to be supportive of all this. I think it makes sense, but I'd just like to know, when it talks about a number of staff who will not be able to move, is it possible to have, I know we haven't done the consultation yet, so we don't know for sure, what sort of numbers are we talking about? The ones who won't be able to move.
Okay, so I mean, I can break that down into a few groups, I suppose. So as we've been discussing the move with staff since October, some of the staff who were working permanently on Hillcrest have already secured moves to other wards and units. They haven't on the whole left Hillcrest yet, but they're wanting to stay in the north of the county, and they've already found themselves vacancies to move into. So nobody's actually left the trust. So from where I sit as Chief Operating Officer, I'll count that as a draw rather than a win or a loss. So I'm happy about that. But that's 5 or 6 staff already. There's a number of facility staff who we know we're going to have discussions with about suitable locations and job roles. And there's a number of healthcare support staff who have already started discussions with, and I say a number, 4, 5, 6, kind of that, who've said, I don't have access to my own personal transport, and I live very close by. And we'll have to have extended discussions. Though there are also a group of staff, as we've proceeded, who've said, look, no, I'm committed to this, I want to make the move. So we've roughed that out. We've made a staffing contingency plan based upon our best estimates of who will probably move and who will probably not move. And we've started discussions. We've had some very good discussions so far with the temporary staffing agents we work with. And we've also secured the services of a large proportion of the temporary staff who work with us on a permanent basis, if you see what I mean. And we've begun the negotiations about how we would extend that contract to fulfill some of that. So it's at a relatively advanced stage, but some of the detail will work its way through when we undertake the formal staff consultation.
Thank you.
Thank you, Matthew. I've got one question for Sue before I then move to summarise and we seek the decision. Sue, you haven't mentioned Healthwatch at all in engagement. Could you offer any comment on our engagement with Healthwatch on this matter, please?
Yes, they've been involved. They were also in attendance at the Health Overview and Scrutiny Committee in October. We meet both formally and informally with Healthwatch, and obviously we have representation from Healthwatch on our Quality and Safety Committee, so they have been party to the conversations. The work we've done with on-site advocacy has been really important as well in this space, because they wanted also to monitor the improvements in the quality of care. So reiterating Natalie's points earlier, thanks to the team, that's been, you know, an incredible feat what they've managed to do in terms of the improvements on the site. But Healthwatch, again, recognising the limitations, have been with us all the way through, recognising that we have got to turn around and make a decision for the longer term here. I'd also like to add in, Mark, that we've spoken to NHS England as well, so they are also comfortable with the approach we've taken to the engagement, and we've kept them updated throughout the process over the last 12 months.
Thank you, Sue. I think that's quite comprehensive. Okay, I think I should summarise this item to, if you like, check what we've just heard and make sure we're all on the same page before we move to decision. And one of the things I heard loud and clear was that the staff at Hillcrest in the last 18 months have been fantastic at improving and driving a far better therapeutic and safer environment. And two names were mentioned, Laura and Anna. Indeed, on my trips up to Hillcrest, I've met Laura, and she is quite inspirational. So it's of no surprise to me that she's been at the forefront of that. But the staff have been excellent. But it appears that the environment there is suboptimal because we can't use the whole of the building footprint. For a number of reasons, sexual safety, for the patient facilities, there's no ensuite bathrooms. There are blind spots where our staff can't observe what's going on as well as they should be in a modern facility, and it's isolated from other mental health facilities that aren't nearby. And there's nothing we can do about those building things. We've done everything we can with the staff, and the staff have done a fantastic job of that. But it's that environment that we struggle to make into a modern facility that is accepted as what is a requirement for an adult mental health inpatient unit. But we have a ready-made solution to those at the Elgar unit at Worcester, in that there is a modern standard, completely refurbished, in fact new facility that can provide those services. We've heard that the most senior trust clinicians support that move. So now I think it's time to hear from the Chief Exec. Robert, can you give us your view on what you've heard, the questions, and what you've heard from your team, please?
Yeah, I'll be reasonably brief, Mark, because the team have gone through this, and I think the important bit to draw out here is clearly we've got professional leaders across the trust talking about why this is the right thing. I'd step back from that though. First of all, we do absolutely have to acknowledge the improvements that the team have made. This isn't about how they are currently delivering care. In fact, it was based on how they're currently delivering care and the improvements they've made. You know, we'd probably be in a different place. This is fundamentally about the environment and things that are inherently not as they need to be. And we have an opportunity to address that. That's got to be right over the medium to long term for our patients in terms of their experience and the care they receive. As John pointed out, that there's lots of benefits here in terms of future training and education and getting the right start for people who want to provide care in the future. So I think for me that this is one of those really important decisions we as a board need to get right. I think we've put the time into it. I think we've engaged correctly, and I think from what you can see today, you've got all of the key disciplinary leads sitting here telling you the reasons why the decision to move is the right one. From my perspective, I'm thoroughly convinced by all of those rationale that's put forward, and I absolutely support the proposal. The final bit I'd say though is, which Matthew was drawing out, we will work incredibly hard with any of our staff that are impacted by this to support them through that. We absolutely don't want to lose anyone. I don't want to lose anyone from this trust who makes a difference and works for our team, and we'll do all we can to work with them to find them a new role or to support them to move. So that's my summing up, Mark.
Thank you, Robert. And to add to that, from what we've heard from Sue, our partners, whether that be Healthwatch, HOSC, ICB, Region, NHSE, are in agreement with this proposal to move forward as well. So I've not heard any dissenting voices on the screen. We haven't heard any dissenting voices within our partners. That doesn't mean to say the move is without challenges. Of course it is. And those challenges are notably around staffing, but as indicated, Matthew and the team have a plan in place to try and mitigate those as best as possible. And as Robert's just indicated, we want to keep hold of as many staff as possible, but we do recognise the difficulties that it brings. So with that, we then move to a decision, and the board is being asked for agreement to approve the proposal to relocate Hillcrest Acute Ward functions to Athlone Elgar unit by April 25. Can we agree that proposal? Or probably the easiest way to say is, does anybody disagree with that proposal? Please say now. I see no disagreement, and in that case, I think we're unanimous that that proposal is agreed by the board, and we will look forward to, as a board, to the oversight of the implementation of that. Can I offer my thanks to the executive leads here and also the teams elsewhere? I know this has been a long piece of work. It has been a difficult piece of work, and on occasions it's been very taxing for everybody, and will continue to be so, I think. So thank you to all that have been involved. Okay, and with that, I think it's time we took a break, actually. So shall we come back to the screen, please, at 11 o'clock, please? 11 o'clock.